Good. So guys, I realised that last night I was a bit nervous speaking to 200 plus people. There's a lot less tonight and only 2 residents left, I see. Of course they wouldn't come back, it's my fault. So I didn't actually introduce myself last night. So my name's Mark, I'm a paediatric emergency specialist, PEM as we call ourselves. There are 2 species of PEM. There's the FACEM PEM, which is the adult emergency medicine who does more experience in paediatrics. And then there's the paediatrician PEM, the RACP PEM, who obviously is a paediatrician and does a bit more experience in emergency medicine. I'm the second kind, so I'm the paediatrician kind, so I'm far more comfortable talking to a family about their child's constipation for 40 minutes than putting in a central line. But I can do both, theoretically. So this talk was supposed to be given, or a second paediatric talk was supposed to be given by Dr. Laura Ellert, a marvellous colleague, but she wasn't able to come to Japan, so I get 2 bites of this apple, which is very kind for Quentin to ask me to speak again, because as you all figured out last night, I do like to talk. I have had, thankfully, a horrible day on a lovely day on the slopes. Thank you, Peter, for taking me out. I've now learned, theoretically, how to ski, and half a glass of wine, 1.5 glasses of wine. So should be a bit more fluid in this talk than last night's talk. Oh, this thing. So I think being modern healthcare providers, modern nurses, modern ambulance officers, modern doctors, we think, and we often are, very good at communication. But my job is in the Northern Hospital in Melbourne. It's an outer metro hospital. It's the second busiest ED in the country, in Australia. The first is Gold Coast, and then Fiona Stanley and Northern generally always vie for second. It's a low socioeconomic area, high immigrant base, low English as a first language. So we have lots of excellent and interesting cultures and excellent and interesting cultural challenges when talking to families. One of my portfolios at the Northern Hospital is the quality and safety, which is basically, they're colouring, fuck-ups and complaints. Sorry. Okay, mistakes and complaints. I went to that again, I apologise. So what I've learned is that even the best communicators have bad days. You can go through a bad day on the slopes, have an extraordinarily sore left side from falling over too much. You can have had bad sleep, a bad pie, and we can all have bad times. So how can we communicate? What do families want from us? And how can we really best deliver communication? Because if you're not communicating properly, you're not delivering healthcare properly, and the outcomes are not going to be very, very good. So what I'm going to do is start with the basic principles. I'm going to give an example of a case. It's an anaesthetic case. Some ILCOR, the International League Committee on Resuscitation, a couple of guidelines and how they're appropriate. Some basic ideas on listening and speaking. Now, it's going to be like I'm telling you how to suck eggs. We really all think we are, and we often are good at this, but there's always something we can do just a little bit better. Conflict is an interesting part. There's a whole series. The NHS does conflict language very, very well, and basically I just want to refer everyone here to that service. Is it possible to actually do evidence-based communication? Yes-ish, yes. It is possible to have some evidence-based communication. Then the power of words, which again, it sounds like we're telling you how to suck eggs, but they're extraordinarily powerful, they're extraordinarily strong. What not to say and why, basic do's and don'ts. And then over many, many, many years, I've learned some really basic, but hopefully honed talks. So with any sort of medical specialisation, and paediatric emergency medicine is a very niche specialisation, I get it. With any sort of specialty, anaesthetics, emergency medicine, peds emergency medicine, it's almost like the 90 and the 10. 90% is the stuff that is boring. It's same. So I can give the fever talk 10 times a day. I can give the Panadol Nurofen talk or Tylenol ibuprofen talk 10 times a day. As long as I get 10% of my job to be a status epilepticus, a status asthmaticus, a paediatric trauma, an odd case. As long as I get something really cool, I can happily do the other stuff. But a neurosurgeon would jump out the window if they had to give the fever talk to a stressed family 10 times a day. Because a neurosurgeon, I assume, just wants to neurosurge, wants to be in someone's brain doing so. But 90% of their job is adults with chronic neck pain, which would make me go mental. So I do those chats very happily, 10, 20 times a day, as long as I get the good stuff. So I'm going to give you some examples of how I do those really core chats. Okay. So this is the really obvious stuff, but it is actually worthwhile declaring it. So the principles of good communication, it's fundamental to have respect. I mean, the people who come to our help often when I read a triage, so-and-so has had one vomit and they're in, and you roll your eyes and you're a little bit dismissive. But when you actually sit down with the family every time, it makes sense why they're there. It's obvious why they're there. So you can roll your eyes, but really they're there for help. And we are in this very privileged position to provide that help for these families who are seeking our care. So active listening, and it feels very weird to give a didactic talk on communication, which is generally to and fro, but we're going to have some to and fro. I won't talk to the residents as much in the to and fro later on, but clear language, jargon is hell. Clear language, active listening, and respect is exactly how we get through it. The ability to acknowledge the family's role in paediatrics especially, we were chatting today. Adult medicine is a dyad of communication. It's you and the patient. Pediatrics is a triad. You've got you with the patient, you with the parents, parents with the child, and it's this spinning disc that gets faster and faster until it falls off. So understanding the family's role, engaging the families at all points. And this is ridiculously easy to get wrong. We need to be very, very clear with what we're doing. Hi, I'm Mark. I'm going to be your doctor for today. What's brought you into the hospital? Okay, now this is done. We're going to have to do this blood test. We might have to do a needle. We'll talk about that sort of language later. We're going to have to move to this. You're going to have an x-ray now. That's actually going to mean we're going to go to a different area, a really cool room. Looks like a bit of a spaceship. Every single step has to be clear. You really got to. It sounds obvious, but it's like, oh yeah, you're going to get bloods and x-ray, and we move on. But we don't explain what that means. We assume knowledge. We live in hospitals. We live in ambulances. We live in these sorts of things. But the families who come in, every single time they come in, it's a horrendously weird environment, and it's easy for us to forget that we live in hospitals and ambulances and so forth. They don't. So it's very easy to do it wrong. Cultural and language barriers. If you need an interpreter, obviously get an interpreter. Try not to make it a family member of the person. If you can use a hospital interpreter, if you're completely stuffed, you sort of do what you have to do. Right. Why am I labouring these almost very obvious points? It's because you want happy patients. Why do you want happy patients? It's not about scores. Thankfully, we work in Australia. We don't have these online things. Your employment and your remuneration isn't dependent on patient satisfaction surveys. But if a patient's happy with their interaction with you, they're going to follow through on an agreed plan that you've come up with them. If they're not happy, it's a bit of two fingers up. There's little people down the front. That's why I'm trying to be over here when I'm rude. It's two fingers up and they're not going to do what you say. And you might say, well, that's their choice. That's up to them. But if I've had an interaction with a family, together we've figured out, hopefully, a very sensible plan forward for their kid. If they don't follow through on that plan, well, I've wasted their time and I've wasted my time. So actually having really good communication increases the adherence to a management or a treatment plan, and it doesn't waste my time. People say, well, that's their choice. It's their right to not do what you want them to do. Fair enough, but if they don't do what I want them to do, I've failed. I haven't communicated. I haven't convinced them that this is the right thing to do, because I haven't convinced myself and my genuine belief that this is the best thing. So it's not about wasting their time. It's about wasting mine, because this is what I want to have the best outcome for this kiddo and this family. So, this case, MC and AC. MC's me, Mark Corden. AC is my youngest child of 3, Antoinette Corden. This was an example of, to my anaesthetic colleagues, really awful communication. When my daughter was 3, she went in for a sort of a semi-elective tonsillectomy, adenoidectomy, because she snored like a Dickens and was at risk of sleep apnea. And she's a horrifying patient to a doctor. Her dad's a doctor, her dad's a bloody paediatrician for Pete's sake, and her mum is a lawyer. A medical negligence lawyer. Not how we met, she's actually the opposite. She is the opposite of an ambulance chaser. Now she works for the Royal Women's General Council, very impressive. But to anyone who went near Antoinette, horrifying patient. Operation went well, and we dropped her off, and like, you give your child over to somebody else. That's for people who don't have kids, you guys, that's horrifying. It's a horrifying thing to give your child over to somebody else to take care of. I mean, for a lot of us who are parents in the room, but it really bears remembering. This is a terrifying thing. Every time a patient comes to you with their kid, they are giving a part of their child to you to take care of. It is horrendous. It's emotional. It's very nasty. So we give Annie over to the anaesthetic team, and they take her away. They anaesthetise her, gas her down, do a drip, and we go out to try and just have a coffee and calm our nerves. It didn't work for me last night. The wine's helping this night. And we get a call about 45 minutes later. Yep, it's all gone well. We're just going to wake her up. You come back in. We'll have her out in 15 minutes. Awesome. We throw our coffee away. We run back into the hospital because, of course, we're upset. My wife is a lawyer, very highly strung. I'm not, but I'm absorbing her anxiety because the families are always going through something when they come into you. Come in. She's not out in 15 minutes. She's not out in 30 minutes. She's not out in 60 minutes. So I go in, I'm like, you know, I don't mean to be a bother. I'm Mark, my patient Annie was on the first one of the ones on the list. Where is she? We were kind of half told. Like, oh yeah, don't worry about it. She'll be out in a bit. Wasn't loving that. And I sort of go back 5 minutes later. I'm like, sorry, I know I'm being a bit bothered, but is it possible I can go see my daughter? She was supposed to be done a while ago. And they go, oh, okay, come in. And obviously everyone's a bit scared. And they go, oh, look, it's okay. She had a little bit of an issue, but she's fine now. She's in the right place. That's a phrase. She's in the right place. She's fine now. That's a phrase. Why now? And she's doing really well. And fast forward, what happened was she would have been extubated, and I only figured this out through supposition. She would have been extubated, but she had an adenotonsillectomy, so a lot of oropharyngeal, retropharyngeal stimulation. She would have had a laryngospasm on extubation. So they would have re-anaesthetised and re-intubated and then slowly done it again. But so an hour later, I've got a kiddo who's narked, who's on oxygen, and the powerlessness I felt, even as a paediatrician, a paediatric emergency specialist, I don't know much about anaesthetics and post-anaesthetic care. I don't know anything about ENT care. So I'm sitting going, what's actually happening? Is this normal? Am I wrong for feeling stressed and upset? And what's actually fucking happening? All I wanted to know is what's happened and why. That's all parents really want to know, is what's happening to their kid and why. And then the inference is, of course, what you're going to do about it. I've obviously been very upset and angry about this case, but no one came out and said, this is what's happened, this is why. We got language. She's in the right place. She's safe. It wasn't good enough. And so we can do simple things so we are good enough. All right, so what's important? Humility. Hopefully the days of the doctor and the nurse being authoritarian is wrong. We should always be seeking for patient-centered care. The kid's the boss. You're the boss. Good, nodding, yes. We have to be transparent. Like, this is what I'm doing, or this is what I would like to do, and this is why. Now, we might think there's no time. It doesn't take long to explain your thought process. If you've arrived at a management plan in about 20 seconds of your mentation, you can explain that management plan in 60. And if you can explain yourself in 60 seconds, you're not wasting time, you're not losing time. It seems trite to be genuine. But we have these jobs. We've flown, genuine's funny, isn't it? We've flown to Hokkaido to have these talks, or, okay, we've come over here for this. But we can also participate in these talks. We really give we really give a care about what we do, and acknowledging who we're dealing with, acknowledging the family as critical parts of the caregiving process. These are the core guidelines, and they're very wordy. Well, not very wordy, the whole guideline summarised into one paragraph. These are the family outcomes on resus. And as an example, like at the end of the wedge, you've got a kid in resus, you've got a kid in the back of the ambulance who's in critical state. What's really important with the families and the communication with the families? Families surveyed said if they were present during the resus, they felt that that was actually a more helpful experience. So I was having a chat to a trauma surgeon at one of the main tertiary trauma hospitals in Melbourne, an adult-based trauma service. But they run regular sims because they're a good service and they want to increase their experience. And they ran a sim on a kiddo, young teenager, 12-ish, who was outside the front of their hospital, hit by a tram and brought straight into them. And his response was, I don't want to deal with that. So we had the parent out in the side room whilst we ran the resus. And I can absolutely understand that. You know, as a paediatrician, I'm very experienced, trained, and I think about constantly how to deal with families. As an adult doctor, as an adult ED, as an adult nurse, as an adult EMS, you don't. They come along and it's horrifying. But when families are involved, the parents do better. They're not disempowered. They're not horrifying sitting in the corner. Because if you tell them to leave, they will leave almost always because they are scared and they are disempowered by the situation that's brought the kid into hospital. But it is better for the parents and they believe that it's better for the child. What's the gold standard? Like, how do we actually make this happen? If you have the resources, you have a specific person who you allocate to the family to talk them through, to explain what's happening. Witnessing the resus helped the parents know that hard work had been done. All had been done is a strong term, but that people really cared, because we do care about this. It's why we've travelled across the world to listen to me speak, skiing. But we do care about these kids. I mean, that's why I want to talk about paediatrics, because people are generally terrified of kids. We're terrified because we care. I'm still terrified of kids every day, but I work really hard to deal with that so I can try and help as many as I can. Parents are allowed to not be present. It's horrifying. We've all got unique lives and experiences. But only 10% declined to be present. 55% of patients who weren't able to be there, you know, the patient coming by ambulance, had a bit of trauma elsewhere, they hadn't come in with the caregiver, more than half had wished they had been. So involving the family is critical. Do we, from a healthcare provider outcome, a lot of people are like my trauma surgeon colleague. They don't want the parents there. They're worried that it's, and the range is sort of 35 to 85%, extraordinarily broad. If you're more experienced in paediatrics, you're more happy to have them in. When I was a very young doctor and I was going to do a procedure like a lumbar puncture or a pubic aspirate or something like that, I would always give the parents a choice. Secretly, I would hope they'd say, no, I don't want to be here, I'm going to leave the room. Now that I'm old, I say, look, when I was young, I kind of hoped you would leave. Now that I'm old, it doesn't bother me. I don't mind either way. But I remember that feeling of, God, I hope they're not here. And a lot of adult people are like, I don't want the parents here because I'm going to feel stressed and so I'm not going to operate optimally. But even for adults, we really should strive in a resus, edge of the wedge sort of environment to keep them there. By the way, if anyone has any questions, queries, comments, concerns, I want to interrupt and have a chat. Obviously I chat, I really like questions. The idea of a talk on communication given didactically is very grating, so if anyone wants to put their hand up at any time, please do. Please.
So when you're talking about having the parent there, or say lumbar puncture, if you've got the child sedated, IV sedation,
Absolutely. If the child is sedated, I definitely want the parent there, at least for the sedation. So so the question was, if I'm sedating a kid, do I want the parent there? In the emergency context, the answer is absolutely yes. There's two main reasons. The first is it's better for the parent, it's better for the kid. The second is the two of the main sedative agents are nitrous oxide. That's pretty safe and happy. The second main sedative agent is ketamine. One of the basic rules is if you go down calm, you come up calm after the ketamine. So the parent there to help the child go through that bit. Once you've explained everything to the parent, because they've got to be on board with this, they've got to consent to the sedation, is better for the kid. With the procedure that I'm doing, you know, your child is sedated now, they're not making memories, they're completely out of it. It's up to you whether you go get a glass of water and a cup of coffee whilst I reduce your child's arm back to normalcy, whilst I do this sort of thing. So they have a choice for that bit, but I ask, and they're allowed to say no, that they are present for sedation. But it's a great question. So, how do you get parents on your side? How do you get kids on your side? You just listen to them. Now, it's not sort of sitting around going, yeah, I'm going to wait till you stop talking. It's listening is a verb, so it's active. You can give them your full attention. So you sit back and you're just like waiting for them, yeah, the kid vomited 2 hours ago, now you're here, I'm not really caring about this. But when you get into it, there's a reason they're there. They don't want to be in your ED, they don't want to be in the back of your ambulance truck. They're only here for a reason. So once you understand that reason, almost every single time your cynicism gets dissolved, goes away, because this is genuine. Even if you disagree with a parent, try to understand what they're doing, and you can use the verbs back. It sounds like you felt judged. It sounds like you were worried. Reflecting back what you've heard is the best way to get the parents on board, because when they're on board, everything happens quicker and smoother. You are not wasting time, you're generally saving time, a lot of time. All right, this is the biggest, most busy slide. Everything after this is a lot easier, I'm sorry. There are studies that if we are better fundamentally with communication, patients have a better experience. They have higher satisfaction surveys, but satisfaction surveys is not just another metric to help impress a hospital administrator. It's a satisfaction because we have a better outcome. So I don't care if a hospital administrator is happy. I care that a family's happy. But these are the metrics that we use, and these are actually helpful. Factors that make communication difficult is you're in the back of an ambulance truck, you're in an ED. It's hard, you feel pressured, you feel rushed. You've got the pressure to be efficient during an interaction. And if I talk too much, I'm not being efficient. But guaranteed, the small investment you make at the start will always pay you back. And that's not me being fluffy bunny, bit of Teletubby Pokemon sort of thing. It really helps you get quicker. Because once the patients and the families are onto that you are genuinely there to help them, they're going to help you help them, and it all just rolls on until they roll out the door, hopefully happy, healthy and well. One of the things though is health literacy. We live and breathe this stuff. We have all the language. Jargon isn't jargon to us because it's meaningful words. We say the word prophylactic antibiotics. We know what that means. It's not jargon, it's meaningful. The words carry meaning. But to a family, it's jargonistic. About a quarter of Americans have low health literacy, and that's not meant to be a derogatory term. If someone was talking about engineering, I wouldn't have a clue. The worst thing to give me is a form to fill out for like a tax return or anything to do with maths or systems. I'm going to freak out because I can't do it. So I don't expect people to have health literacy because I don't have literacy in any of these other fields. I obsess over this and this alone. My wife does the taxes. I genuinely can't do it. However, we overestimate everyone else's ability to understand what the hell we're saying. We overestimate health literacy by about a third of adult patients. So that's shocking. The easy way to get around that is ask. This is what I've said. It's a bit weird what I've said. You're in hospital, that's a bit weird. You're having a terrible day, which is why you're in hospital in the first place. Do you understand everything that I've said today? You just have to ask. But it's knowing to ask, especially for the residents. Like you're obsessed, hopefully, as much as I am with this because you are learning. Someone did a great question yesterday about how much calcium flies off when the rotor goes through the artery. I thought, I haven't thought of that. It's a brilliant question. So the future of medicine's very secure. But you just have to ask, because they don't know what we know, and they're not supposed to. We're supposed to, and we're supposed to understand that they don't. All right. One of the things I want to talk about is conflict language. Now, this is an NHS initiative called Civility Saves Lives. There's an incredible TED Talk by a guy called Chris Turner. It's about a 15-minute TED Talk. I can send you a link if you want to email me, and it's one of the best things out there. Now, this is a language issue to do with intercommunication between medical staff. However, the principles are fundamental and they apply. If you've got conflict, I was discussing conflict with one of our colleagues today, conflict in the negative term, that you're just shouting words at each other and no one's actually listening. Conflict in a constructive conversation is high, but if you've got conflict between colleagues, the game's gone. If you have conflict between yourself and a family, you've absolutely lost. You've got none of the positive health outcomes we're talking about. But even in a resus scenario, sim-based scenarios, if you have conflict in a sim, the outcomes in the sim are much lower. Even indirect conflict. There was a study where a sim's going on, one of the team members has to answer a phone call, and the phone call is conflictive. So just one member having a private conversation creates conflict, tension through the whole team. Tension absorbs our attention and our ability to focus, and our outcomes are lower. So when we have conflict, we have reduced mortality rates, reduced patient satisfaction, and reduced staff satisfaction, reduced everything. So the ability to be civil, and civility saves lives, it's not just fluffy bunny stuff, it's evidence-based stuff. So the ability to be civil at all times is fundamental. Disagreement is fine when it's constructive, but disagreement when it's conflict is different. So there's ways we can handle ourselves with each other and with families. Okay, is evidence-based communication good? Yes?
And I was just going to say, I think it's really important to bear in mind that spans across not just EDs, but emergency and then back to the GPs. Because, I work in a few fields, but as soon as there's conflicts, if they said this is ED or so on and so forth, it falls apart. It takes a bit of effort to talk to patients.
Yeah, so the point is, community-based medicine versus hospital-based medicine, and so like the standard hospital. I mean, the hospital is the whole ED is Jon Snow from Game of Thrones. You know nothing, Jon Snow. You refer a patient to a specialty service. They go, "Oh mate, what have you done? Or why haven't you done this? Don't you know?" But that's the same if you take a step further back from the hospital-based specialist to the community-based specialist who has sent a patient in for a review of a diagnosis, a specialist test, and the hospital goes, "Oh, come on, don't you know?" And so that creates issues. But think it through to the end. You've got conflict between two healthcare providers. From the patient, they've got their doctor and the hospital doctors. Both are eminent in their own ways, but they're not agreeing. So when doctors aren't agreeing, how the hell is the patient supposed to participate in their own healthcare? So guiltily, as a resident and a registrar, I absorbed a bit of that culture, and I would roll my eyes at some of the GP referrals. Now that I'm older and hopefully more sensible, I'm never going to roll my eyes at a GP referral. They've seen a patient, they've done their best. A GP has to see everyone from 0 to 100 plus, and have to do it very quickly. I don't have any of that. I just get to see kids, and I get to see kids in a hospital environment, so not the back of an ambulance truck. So I've got obs on a chart, I've got colleagues around me to discuss with, I've got time. All the things that my GP colleagues don't have. So I'm never going to say a bad word anymore. Sometimes I will make a phone call and say, "I can see why you said this, here's what happened, and here's why you might do something well in the future." Often I've made a call to a GP practice going, "That was a great catch." But any conflict between healthcare providers, any conflict between yourself and a family, yourself and a patient, it's only going to have negative outcomes. So we can work simply to try and get around it. Can we work in an evidence-based manner? A little bit. So I've got a few studies to discuss. One's from the BMJ, and I really should do less of this animation stuff. This one is a fabulous study. I love it because it actually experimented more on the doctors than it did on the patients. So the doctors were basically the test. They had 125 patients. Basically half were, chair was pulled out and plonked next to the bedside of the patient. This is an inpatient thing, less emergency, but the principles are very applicable. Standard in this hospital, this study is the chair is kept in a bloody cupboard. So that little schnick is the chair. So half, roughly, standard therapy, chairs in the cupboard. Why chairs in a cupboard, I don't know. And then the experimental is pull the chair out and plonk it next. You can manipulate a doctor, and we do like manipulating doctors. 2/3 of the doctors sat down when the chair was there. So it's an experiment on the doctors, and it's fantastic. And less than 10% actually pulled the chair out to sit down with the patients. When the chair was out, when the doctor sat down, there was no effect on time spent in the room. So sitting down to chat to your patient, instantly, it's less confrontational. You are definitely on the same team now because I'm at your level. I'm not standing over you. Doesn't waste any of that time. Doesn't take more time. And the TAISH and the HCAP score is an American executive sort of score. Basically, it's patient satisfaction and communication surveys. Just getting on the level, feeling more human. The patient feels that you're a bit more humanistic than just a doc, some sort of faceless person. So very, very, very simple. The nudging is just chucking a chair there and saying nothing. Yes, mate. I think the doctors did. So this is the doctors. They may or may not have known, but it was standard hospital policy in the hospital that they were employed that there is a chair in every room. So whether each doctor knew it was there or not, I don't know. But these were attending, so consultants who clearly had worked there for a bit of time, had employment contracts. So I don't know that if the doctors individually knew, but I think it's the assumption through the article was that it was known. It was a known that the chairs were there. So simple things. Too much animation. This is an ED specific one, so not an inpatient one, but very, very analogous. This study was nearly 3,000 patients, so much, much larger. They had these weird looking little stools and a weird looking little study infograph plonked in each of the cubicles. Sitting at any point in an ED, so this is more of an acute thing, like you hear, it was quick, we're busy, it's noisy, there's machines flinging everywhere. Sitting at any point, so not for the whole time, but just sitting even for a bit, increased the responses. So doctors, healthcare providers, nurses were, I'm sorry for the formatting on listened, but they were thought to be more polite, more informed. And although it didn't actually change any of the time, the patients felt that more time had been spent. In the inpatient study, the patients did not feel, when surveyed, that more time had been spent, but they still had better outcomes. But in the ED, it actually felt that more time had been spent with the patient, even though more time had not been. So, sitting, simple, ridiculously effective. All right. A journal that I didn't know until I was writing this talk, the Journal of Patient Experience, which is now actually one of my favourite journals. This quite large article had 220 people, and it was a survey, it was a qualitative-based study that looked at words that doctors and nurses and everyone have used to you that didn't make sense. And a third, basically, almost a patient. Common terms were about really technical terms that a patient really shouldn't know. If someone comes in and says, I've had polydipsia for 3 days, I'm like, what's your job, mate? You know, if a parent comes in and says, oh, my kid's been febrile for 2 days, I'm like, febrile, that's an interesting. I'll always finish the interaction with the parent and the examination, and at the very end, I'll say, not many parents use the word febrile. What's your job, by the way? So don't let knowledge of their job colour everything. Have it as a nice sort of open-ended thing. But at the end, knowing what someone's job or experience is does impact your ability to communicate with them. So it's all valid. So terms and technical phrases, jargon was a problem. And at each phase, so the diagnosis of confusion, or if we become a bit too redundant, if we become a bit too paternalistic, oh, you've got some kidney problems. Well, that doesn't mean much either. So it might seem hard not to be too specific or too vague. But if you just say, you've got this condition, and that means this, that's simple. You can give the technical term and then explain what the hell that means. It doesn't take much longer, and it doesn't affect your end time. And at each start, the treatment, all of these terms, NPO, no one knows what that means. We don't even use that acronym in Australia. The medication, giving someone a script. I had this exact thing only 2 weeks ago. One of my senior registrars, a doctor that I really rate, someone I would let take care of my kids, which is very high praise for any doctor. And that's kind of the goal for a paediatrician, to be good enough that other people want you to see their kids. That's our goal. So I would let him see my kids. And I had just started my shift. He'd been on the day, I was taking over in the evening, and he was just discharging a patient, and they were going home, and the mum said, oh, is 2 times a day right? It was a discharge antibiotic. He's like, yeah. It's just prophylactic anyway, so 2 times a day is more than fine. And she sort of nodded and left. And I asked him, was that mum a doctor or a nurse or an ambo? He's like, no, I don't think so. Why did you use the term prophylactic? You know, we know what prophylactic antibiotics means. He's like, oh, yeah, I probably shouldn't have used that term. It was meaningless to her. It was confusing to her. I saw her leave with a funny look on her face, but I hadn't even put my bag off my shoulder yet, so I wasn't able to sort of stop her and go through it again. But a good doc, someone who I rate, when he's busy and distracted, can still lean back and sit back on jargon. And that's something we can avoid if we try. And it doesn't take much effort to try. Same study, going through, especially with follow-up. Follow-up is very, very, very confusing for patients. You know, you're going to have to come back here in a week or 2 months. I want you to see your ED, your GP to organise this test down the line. It's horrendous. So we need to explain in as clear language as we can that's meaningful at every step of the process. It sounds obvious, but we continuously, as a group, as healthcare providers, don't do it well enough. Okay. Words, the language that we use. I'll wrap up soon. Can also think. So this is an older study, it's nearly 20 years old, and it was videos that looked at interactions of patients. And again, it was a trick on the doctors, because the doctors thought they were being interviewed and they were having their interactions observed for a trial where hypnosis was going to be used. It wasn't. They were just looking at the language that was being used. And when patients are warned about pain, so you're going to have a needle, it's going to hurt. When we warn them about the pain, when we use the word pain, it was a self-fulfilling prophecy. There was more pain. If you give someone a vomit bag, they are more likely to experience nausea and even more likely to vomit. We know these things are real, but they are so viscerally present in almost all of our interactions. Sympathising in after, oh, I'm sorry, that was really painful. That didn't have more pain, but did create more anxiety. So the words we use are extraordinarily powerful. So can words hurt? Let's give me some propofol, kill Michael Jackson, be fine. Words can absolutely hurt. We need to be very careful and judicious. So how can words hurt? When parents are stressed, and if you've ever had a sick kid, you are stressed. Also, your kid's probably been sick for a day or 2 days, so they haven't slept, so you haven't slept, so you are absolutely not mentating at your best. Words are extraordinarily hypnotic. They immediately become high risk of self-fulfilling prophecies. So, placebo, I wrote this down. Placebo, I think, comes from the Latin for I can help. I really want to get this right because I love Latin. I shall please is where placebo comes from. And the nocebo, the opposite. I was worried that nocebo was going to be like a kitschy phrase playing on placebo. Thankfully, nocebo also comes from the Latin, which means I hurt. So the placebo and the nocebo words really actually make a difference. Minimizing words. It's a tiny sting that will only hurt for a bit. What words are the patients going to remember? Hurt and sting. They're not going to remember tiny. They're not going to remember little. They're not going to remember just a bit. And this is not just me pontificating. This is, again, real. Minimizing words don't help. So you can say alternate words like, there might be some discomfort, not pain. Discomfort's a bit more... Yes, mate?
I don't even talk about discomfort. I'm going, this MLR patch that we put on, this will make the skin quite numb. You're trying to be using words to sort of put that kind of language into the kid's head.
For paediatrics especially, we're going to put some cream on, it's going to make your skin feel a bit funny. I don't even use the word numb anymore because kids don't know what that means. And some kids have had issues with the word numb or being dumb. So we're going to put some cream on so your skin will feel tingly, it's going to feel weird. And when I take the cream off, I'm going to show you how your skin feels weird and different. So if I do a blood test here, where there's no cream, it might be, you won't like me. But if I do the blood test here, where the cream is, we're going to be fine. And the same language goes for, just aside from when we talked about sedations before, a colleague of mine once said, oh yeah, we're going to give you this thing, we're going to put you to sleep. And the child's dog had been put to sleep just the week prior. So with regards to ketamine, I never say that line anymore. I'm saying, we're going to give you this medicine and it's going to put you into a really heavy dream. And because you know you're going to have a dream, you get to choose what you dream about. If you think about the thing you want to dream about, right, we'll give you the medicine. I don't know, I've consented the parents with ketamine, but the kid doesn't give two hoots what it's called. When we give you the medicine, you're going to have this really great dream, and then when you come up, you tell me about what you dreamt about. I can't wait to hear. I had a kid a few weeks ago. I did have this kid, but every time I talked to a patient, it was always a few weeks ago. It was a 5-year-old. He woke up from ketamine and says, I dreamt about pirates. And it was great, but it does work. It's suggestive, but ketamine is obviously very dissociative. So, obviously, things not to say. Trust me, I'm a doctor. I mean, you sound like a schmuck. But also, it doesn't work. It's counterproductive. What do the parents say? They hear, I'm smarter than you, I'm the boss, you're powerless. It's how I felt when my daughter was having problems and complications that I wasn't being made aware of. Even as an absolute paediatrician consultant, I was made to feel powerless. And that's exactly how these parents feel. It's how your patients feel half the time. I mean, you have an elective surgery. You go into hospital, they give you some paper undies and a gown that doesn't close at the back and a hat, and they lie you flat and they push you around. You are powerless often as a patient, and it's easy for us to forget that. But what are you trying to tell a parent? Please trust me, I know what to do. Well, that you can say, this is really scary. I have been reading about this for donkeys. I've seen this before. This is what I think we should do, and this is why. Explaining your thought process justifies the patient's stress. It tells them, I'm thinking about it, and this is how I'm thinking about your child, and then we can move on. Don't worry about that. Means there's something to worry about. Really. It also means your thoughts and feelings are invalid. You're being a bit histrionic. Don't use the term hysterical, because hysterical is a gendered term from the general mania that you had 3,000 years ago because you're a woman with a uterus. Histrionic is from the Latin for being dramatic. Hysterical is a bit sexist. So you're dumb, you're wrong, and your feelings are and your thoughts are invalid. But what are we trying to say? So this is the one time when I want to stop being didactic. What other things are shit to say to families?
Can I just add something?
Please.
Like communication, what you're talking about is really great, but I think we need to be mindful when we're not even near the patient, but they're in hearing distance. Because often there's conversations that are made about the family, about the child, and advice involved. And, especially ED environments, you can hear everything. So it's just something to be mindful, I think, that we think where we are, what we're saying to our colleagues about the patient when they can
extraordinary. For the people at the back, the comment was around minding your language. I mean, if you're going to say something disparaging about a family, you probably shouldn't say it out loud, ever. But if you do have a conversation in a place, the workplaces that we have, so EDs, wards, ambulances, it's never private. So patients will hear them being disparaged, and that's it. Again, the game is lost. So the comment about minding your language and just being genuine and thoughtful when you're interacting with the family directly is extraordinarily valid. But also equally, when you are talking about a family, because negative language begets itself. When I was young, I was practicing, without knowing, being cynical like a cool dog. And now that I'm old, that's shit. So it's the language that we use with each other that can help create a better environment. If we're always negative about our patients, it's a negative place to be. So it's always a bad idea. But your point about it being a bad idea within earshot is very, very bad. There was even an example at my workplace. We have those workstations on wheels, computers on wheels. We call them wows now because we used to call them computers on wheels, cows. And someone made a complaint because someone said, I'm just going to deal with that cow in bed 3. And they thought they were being referred to as the patient being the cow. Language is powerful. What else shouldn't we say? What other examples are there? So if you say no to a family for something that they want, it's interesting. I think being genuine is the key. So when I got a ring on my finger, instantly more parents, more quickly. You're exactly right. I'm old, which is I think half your point. I'm old and I have 3 kids. So I've got a ring on my finger and I've got the bags under the eyes that tell a lot of people, I have done this shit for years now. I know where you're coming from. But as a young person, when someone says, do you have kids? I know some excellent paediatricians who don't have children. Paediatricians I would take my own kids to. So you can say, look, no, I don't have kids. But this is why. But I understand that you haven't slept in days because when your kid's up, you're up. That's obvious. You can say things that are obvious without having a lived experience. So when your kid's up all night, you're up all night and you're tired. Your child has this diagnosis and this is what we're going to do to deal with that. So you don't have to, I have some registrars who pretend to be parents sometimes in that exact scenario. I don't advocate for lying. I don't tell them off, but I don't advocate for lying. But there are ways around. You can empathise. Your kid's been sick for days, they've been up all night, so you've been sick for days and up all night. This is what we're going to do, and this is why. So you can still be extraordinarily genuine, even if you're not a parent. So there's no quick fix to that, but it doesn't replace how we deal with it. But thank you for calling me old. All right. So what to do? It doesn't have to be that hard. At the end of the day, sit down. If you're dealing with a kid, kneel down. I've got very terrible knees, but I will still always kneel down and chat to a kid. Because if you're standing over them, you are giant, horrifying. And they're already scared and confused. They're not in their home. They don't know what's going on. And then you're this ogre. I mean, you're lovely, but you're ogres. So kneel down and have a yarn to the kid as best you can. The trap with paediatrics is to reassure too soon. Don't worry about that, but they are worried about it. So explore why they're worried. Then you can address the worries instead of just reassuring the worries. Reassuring too soon is horrendous. So can I have 4 more minutes? Thank you all. So over many, many years, I've got 2 talks. The fever talk and the pain relief talk. I'm going to give them both to you now. So parents are always horrendously scared about fever. We spoke about it yesterday. Fever is associated with serious bacterial infections. They're worried that the thing's going to die. What are they really worried about with fever, as an example? They're worried the fever's going to cook the brain. Laughing, yes, because this is exactly what the fever is. And the worst thing to do is, don't worry about that. Fevers aren't going to cook the brain, they're good for you. Sort of. The way I deal with the fever talk, and it is the fever talk, it's when we were kids. So again, it's the old bags, ring, grey hairs sort of thing. When we were kids, already it's we language, not you and me language, not I'm the doctor language, it's we language. When we were kids, and you're kind of moving around to the side, we're right next to them, our mothers and fathers, our aunties and uncles, all thought a big fever's going to cook the brain. It's like, yeah. Frequently this is the fear. Thankfully, since we were kids, more me than you, 45 more years of research in pediatrics, we now know that's not true. If you immediately attack the belief, if you tell me something you believe, and I say, that's not true, what happens? What do you feel? You feel tense. Your reaction is a bit of on front too, right? Okay? So if I contradict your belief, which you've had your entire life, because everyone in your culture and prior generations has told you this, your lizard brain activates, your reticular activating system in your basal stem activates, your blood pressure's up, your heart rate's up, your tension's up, and the game is lost. So, you displace the responsibility for the belief onto the older generation. You know, our mums and dads, aunties and uncles, you keep it non-gendered, they all thought this. Bless them, but this time they, not you, they were wrong. Fever exists. I mean, fever is natural. Fever exists for a good reason, two very good reasons. The first reason is, in the setting of a fever, our immune system has a bigger response. We make more antibodies, the things that help us fight infection, and this is entirely true. And the second reason a fever exists, right, it's natural. What a great word, natural. The reason fever exists is the things that make us sick, the viruses, the bacteria, the fungi, that sort of stuff, they like us the way we are. So when we change the game by going hot, it makes it harder for them to make us sick. And again, that's a valid point. The proteins and enzymes in the viruses and bacteria have a narrower range of temperature tolerance than our proteins and enzymes. So, our mums and dads were lovely, but this time they were wrong. Technically, fever is natural. Technically, fever is good for us. But it still makes the kid feel rubbish. You're justifying them. So what do? If the kid is hot, I don't much mind what the number is, 38 to 940, hot is hot. If they're hot and happy, then you let the fever do its job, communicating that there's a function to it. But frequently, if they're hot and unhappy, that's Panadol Nurofen time. And that's it. You displace responsibility for the belief, explain a little bit without using jargon. And I've had so many families go, oh, that makes sense. Because that's the whole point. The pain relief talk. This is much more relevant to the parents who've been up all night. Because I will get lots, we think it's obvious. We know that paracetamol, acetaminophen, Tylenol, Panadol is Q4 hourly, max 4 doses in a day. And Nurofen is Q6 hourly, max 3 doses in a day. And if you explain that, factually perfect information to a parent, they are going to assimilate none of it, and it's going to be meaningless and confusing. And I say that, technically Panadol is 4 hours, you do 4 in a day. Nurofen's 6 hours, you do 3 in a day. But when my kids are sick, my kids thing, and they're up all night and I'm on, I can't remember what the hell I've given. I'm not clever enough to write it down and put it in an app. So what do? If my kids are a little bit crook, because they're all daycare and school kids, they're always sick. If they're a little bit crook, I'll give them Panadol or Nurofen, whichever one. In my house, it's generally Nurofen because they like the flavour better. But I'll give them whichever one. But if they're properly crook, miserable, not eating, not drinking, flat on the floor or on the couch, I'll give them Panadol and Nurofen together, which means I have 6 hours to try and get some food and make them happier and drink and some juice. And then at 6 hours, I'll have a look at them and go, okay, mate, what do you need? One or both? And that's the pain relief talk. Very, very simple, but you can see how in a lot of the other ways, it's confusing and demoralising for the families. I've lost my clicker. All right, so I'm actually finishing up now. This is just everyone's always done it better than me. This is just a basic sort of summation of how to actually talk to families. Be clear at all times. Remember that they're scared. Remember that they're tired. And sit down and you'll be able to actually talk really well with these guys. Thank you very much.
Thank you very much, Mark. Unfortunately, probably we'll be pushing a little bit for time if we take questions now.
I'll
I'm
hang
sure
out later.
Mark will be very, very happy to have a chat with anyone who do have any questions. You know where to find him, maybe near the red wine.
Yep.
So let's take 5, and we'll see you back here shortly.
Made it.
Now I can relax.
You're gonna have a really good night.